I'm really sorry about the delay. Something happened. So, my name is Jens Lundbaek. I'm a psychiatrist, forensic psychiatrist from Denmark. Previously, I've been in research for many years in a whole different fields, which is physiology and biophysics, but for the last 15 years, I've been in forensic psychiatry. The idea of this talk today is to give you kind of an idea of how forensic psychiatry could be. But I think when I start with all the things we do, very fast you'll go, yes, but what about the resources, right? Because when I hear you see 40 patients a day, I'm like, okay, maybe you have more important things to do than to set this up. But this is just something that you can maybe think about how it could be done. I come from Denmark. I don't know if you know where Denmark is. People in Denmark don't know where Rwanda is, but it's up here, this guy, there. Sometimes when I give a talk, I ask the audience some questions. Are you going to answer if I ask you something? Maybe not. We'll see how it goes. So first we'll see, what is it a forensic psychiatrist does? And then we'll see what's forensic psychiatry like in Denmark? How is it we help the court? How is it we write the forensic psychiatric assessment? How is the forensic psychiatry organized in Denmark? And something about how we treat the patients and how we try to prevent violence. If you define, do you all know what forensic psychiatry, do you all have an idea about what forensic psychiatry is? Not necessarily. It's a subspecialty of psychiatry in which scientific and clinical expertise is applied in legal contexts involving criminal and legislative matters. And that's a fancy way of saying it's an interface between law and psychiatry. That's where the psychiatrist collaborates with the court, with the police, and that means we have not only our usual role of being a doctor, we also have a role of protecting society and prevent further crime. And that means sometimes your role is a little bit different, because usually when you're a doctor, you will do anything for your patient, but you always have his best at heart. You want to do it the best way for him possible. And we of course try to do that, but we also have another obligation, and that is to prevent further crime. What we see, what is it we do in our work? First, when a criminal offense appears or before a judge, someone who might be guilty of something, in some cases the judge will say we need a psychiatric assessment to see whether this patient is mentally well. So we do this, we write these assessments. We see if they have permanent disorders or if they were briefly psychotic at the time of the crime. And we also do a risk assessment, meaning that we say, well, if this guy is not in treatment, what would be the risk to society? After court, it's our role to have the patients both in treatment. We give them medication, psychotherapy. We collaborate with other social services. Once a year, we write to the court and say, in our opinion, whether a certain court order the court order for psychiatric treatment, whether that's necessary that it continues. Interesting thing is, what we write in these courts is not whether it's fair that the patient still have this court order for all these years. The only thing we have to look at is whether, if the patient didn't have the court order, they might do something criminal again. Sometimes I talk to some people in Denmark and they say, well, the guy broke some car's window, right, or did something not very serious. He might have gotten like a month in jail or something, or a fine or something, and instead he is under psychiatric treatment for 5 years. But I always try to explain to the patients that it's actually something that's true. Of course, everybody wants to be a free person. You don't want to have to show up for meetings. You have to do this and that. But the good thing is about it is we have much better resources than psychiatry in general because of the risk of drug. So therefore, they get our nurses. Normally in Denmark, I'm sure it's the same here. You will see a doctor take months to see a doctor. Because these patients are quite dangerous, they can get in contact with me in the same day. Report to police does not mean that we call the police and say, now this guy has committed a new crime. We would not do that. If it's like stolen something or doing drugs again, which is illegal, or selling drugs and so, it's not our role to call the police. But it's our role to, when the police has found out something and they might want to take it to court for the patient for a judge to decide whether they should still be in treatment or in punishment, then it's our obligation to write. We think no, this patient is still mentally ill. He might have done something wrong, but we can't really blame him for it because he was severely psychotic at the moment. So here again you can see, So here again you can see the kind of double role we have. A lot of our patients, for instance, smoke hashish, which is illegal in Denmark. So what are we going to do about that? I don't know how it is in Rwanda, but in Denmark, if a patient says something to a doctor, the doctor is not allowed to call the police and tell them, unless it's something very, very serious. If a patient tells me, I'm going out and kill a guy tomorrow, then I will call the police. But if he told me I stole some amount of money, or I'm going to steal some amount of money, if it's not in forensic psychiatry, we wouldn't. It's not my role as a doctor. My role as a doctor is they can tell me anything. But here, as you can see, in this system here, we have sometimes our role is a little bit different. Also, we have to a little bit keep track of what they are doing and whether the criminal offense is so serious that something has to be done about it. And then back to the hashish again. Even though hashish is illegal in Denmark, I don't intervene. I could intervene. Some of our patients get it's very strange. Hashish works in two ways. Could you call it hashish also? Cannabis, something like that? Yeah. Some patients get relaxed. I always tell them that you also get, you might say you get relaxed, you will also get paranoid and depressed. But in the long run, for some patients, they use it as a sort of a self-medication. And I don't intervene there. But a few of our patients actually get very psychotic and very dangerous when they smoke cannabis. And in those cases, I would say, this is not allowed. But it's just to show you that we have two roles, not only being a doctor, but also a little bit being a policeman. Let's see here now. We have a criminal offense. Person appears before the court, the judge, and the judge has to decide whether the patient should have punishment or he should have a court order to follow psychiatric treatment instead of punishment. Let's look at this process. This is what we call the busy slide. So you should focus on different aspects of it, and I will get back to it later. What we see here, the criminal offense on top, the blue one goes to court. There, it's the judge who decides, should we send this for a psychiatrist to do an assessment whether this patient is mentally well. And then it can go back to court again, and we can tell him as a psychiatrist, I think he's psychotic, and therefore we should suggest no punishment. The other possibility is, of course, that they get a punishment. Next slide. So when does the judge ask for a forensic psychiatric assessment? They do it in cases where a patient has a known mental disorder, or we have somebody who's showing up acting weirdly, and he has no record of being a psychiatric patient, but there's something odd about him. So say, well, is he really well? There you need a psychiatric assessment. And then in some cases, or in all cases where you have the very serious crimes, murder, sexual offenses, arson, you always get an assessment from a psychiatrist. Next step. So what is such an assessment? It's something that's extremely thorough. It's either done on inpatients or outpatients. It has a fixed format. You can yet get a complaint if you just write, I think this patient is not well. They will send it back to you. There's a very fixed format that has to be, and if you don't do it well, then you are in trouble. You have to follow this format. There's 15 hours for it, and there I'm getting back to like the question also of resources. You go through the childhood, adolescent, adulthood, you go school work problems, prior criminal offenses, whether they use drugs, and separately from what the psychiatrist does, also there's a psychologist who does tests of IQ, possible personality disorder, or autism, or malingering. Do you all know what malingering is? I ask you to help me all day. What is malingering? Anyone? Please. Do you know what malingering is? What is malingering? It's when you fake a symptom. It's like when you say, I hear voices, but you don't hear voices. Because sometimes patients say, even though I just told you some patients might want to, they'd rather go to jail for 1 month than being under our supervision for 5 years. But in some cases, when they have killed someone, they might go to jail for many, many, many years. But instead, if they say, I hear voices, I see little ants walking on the floor, there they try to present themselves as being insane or psychotic. That's called malingering. There are actually some tests for that you can do. Then you can also always ask yourself, would I be able to cheat even on these tests? But I think they are made in a way so you're supposed to, so actually shouldn't be able to. But anyway, the psychologist made some report. Psychologist's report is always full of all kind of tests that we have no idea what it is, so we always go to the conclusion. And we see, okay, so what it is about. What we should decide, at the time of offense, can we say that the patient was insane, psychotic, or had his very low IQ, or for instance, a personality disorder? We give a recommendation. So we say to judge, we think this patient should have a punishment, or we think they should have a treatment. Can you see, when you do this kind of psychiatric assessment, what could be a problem if the patients were still using drugs? And we wouldn't know about it when they do this, when we do the assessment? Let's say he's taking cannabis again, or LSD or something, cocaine. These drugs can all make you psychotic. So therefore it can look like a disease such as, for instance, schizophrenia. So therefore we have to make sure that when we do, and this is over, this can take some years, this can take some weeks to months to do these assessments, But if they go down every day in the courtyard and smoke hashish, you have no idea what it is really you're looking at. So you have to make sure that they are not using drugs. Just to show you some of the diagnoses that cause that you don't get punishment: dementia, delirium, schizophrenia, bipolar. You can more or less lump it together and say that seems okay because these are the situations where you're psychotic, you are not yourself. It's not for you. You can do. We could all in those states do something that would be against the law. First thing would probably be shouting in the street, kicking someone. We could all end up there if we had one of these diseases. Next slide. So now we are here. We have the criminal support. The psychiatric assessment has been made. Then we have two, in the law, there are two situations that come up. Either they will not get punishment, or you say they will not get punishment if it serves the purpose of preventing crime. Let's see. You see here it says incompetent at the time of the crime due to severe mental illness, for instance psychotic, or that they have very, very low IQ. Or the less severe ailments down here, if you have a personality disorder, autism, something like that, we say, well, it's not in all cases that we say they shouldn't have no punishment. It's kind of what it says, it serves purpose. And that means after some years, what we see, they still do crimes. Then we might say, okay, no, this doesn't work, they have to have punishment instead. But that's only for the less severe mental disorders. The reason I have highlighted, and that's very important for the whole forensic psychiatry, the reason I have highlighted incompetent is because it's for the judge to decide whether you're incompetent. So the psychiatrists give a recommendation and say, well, he was insane, he was psychotic, he did so and so, but we are never allowed to say whether people are competent. That means, in a sense, whether they are guilty. An example could be a judge, and that's very, very rare. It's in very few cases, a judge says, well, he has schizophrenia, but he's been well treated for many, many years. He's not psychotic at the time of the crime. He knows what he's doing. And that's more or less the core. It's not for us to decide whether people know what they're doing. We're just saying, from a psychiatrist's point of view, they are mentally ill. So you can say, in the end, it's also in a way for the system to work so that the judge has the final decision. So he decides whether it's really competent. Next slide. Just a few short side view to explain psychiatry in Denmark. And this is not for psychiatry, because in a moment I'm going to tell you that for instance, I can commit patients to the hospital against their will when they have a court order. I just want to say this is not something you can do in general to patients in Denmark. In general psychiatry, which is not forensic psychiatry, you say everything is voluntary unless the doctor decides you're a danger to yourself or others, or that you need treatment. Dangers to self or others, that's easy to explain. What does need treatment mean? Well, it's the guy in the street that you see is like forever and ever. He's for months out there, he's just walking about. He's clearly psychotic. Somebody needs to take action on this. And in those cases, we can also, even though they are not dangerous, we can say, you must come to the hospital. Such an involuntary abasement is a GP, some doctor writes a report. He calls the police. The police takes them to their psychiatric ward. And in the psychiatric ward, another doctor has to say, I agree this patient fulfills the criteria for an involuntary treatment. Because otherwise we need two doctors, because otherwise you can just say, I don't like my cousin, he's probably insane, and just having it. You always have to have two parts that to check the situation. Regarding the medicine, we get back to that, something you can only do on inpatients. And then all patients have an advisor, because when you are mentally unwell, you are not very good at defending yourself, meaning in the case of the law, and so therefore we all patients are given an advisor. Next one. So what is forensic psychiatry in Denmark? There's about 3,500. 90% are outpatient. That means they have to come, show up to talk to the doctor or the nurses. If they don't show up, we will have the police come and get them. 10% of them are inpatients. We have 40 the most dangerous in Denmark altogether. They are all in seclusion rooms and extremely dangerous. The more normal situation, the patients that we work with are these that when they are considered dangerous, we say you must go to the hospital. So back, please. Yeah, you must go to the hospitals, and they are just admitted to the general psychiatry hospital. These are these guys, and then we have specialized forensic psychiatry departments. It's important for us to try to tell them, even though you are now under the Social Criminal Act or so, that we don't see them as criminals as such. They also have connections to people from criminals prevention, whatever support. And I always say to them, also if like I have a parent and they see suddenly their daughter is characterized as a criminal, I always tell them, well, they broke the law, but we don't see them as criminals as such. Next one. So what does it work like? For instance, where I work, there's one doctor, 8 nurses, social worker, psychologists. We have these patients. The nurses meet or contact the patients from daily to monthly. And that is the daily one in general psychiatry is totally impossible in psychiatry in general. But that's simply because sometimes when I tell my friends, at a dinner about, of course, I'm not allowed to mention names, but about some of the people that are walking around in society, and they are like, how can you let these people walk the streets? And all we can say is because we follow them extremely closely. And if if we see that they are deteriorating, then they come every day, for instance. Then we do urine tests for drugs. We go elaborate supported housing and social workers. As a doctor, also you need patients. You do treatment, you do risk assessment. But one of your most important jobs is simply to say, should this patient be admitted? Because the only thing I can do, even though they have a court order, I cannot say you must take medication. I cannot say you should do this and that. I cannot even actually say you're not allowed to smoke cannabis. But I have only one, so to say, button I can push, and that is, if you continue this kind of behavior, I consider it too dangerous for you to be in society, so therefore I have to admit you. So, for instance, I cannot say, stop smoking cannabis. I cannot say that, but I can say, I think you will be too dangerous for other people if you continue smoking cannabis, therefore I have to. Then I think something that's important when you compare such a system with Rwanda and Denmark is the role of the family is entirely different in Denmark as opposed to here. I think everybody here is part of, must correct me if I'm wrong. Let me start it this way. In Denmark, a family is considered one father, mother, 2 children. That's it. You don't have the connection with the whole family group that support you. But that means also, like, if you have a psychiatric illness, the parents mostly are always the last one to give up. The siblings go like, well, I've been trying to help this guy for like 10 years. He always end up with problems because he's schizophrenic. I can't do it anymore. So they end up being isolated. Usually it's the parents that hold out for the longest time, but at some point they don't have the family support any longer. And I think that's something, so therefore we have, you would say we have more provided by the government, but we have far, far less provided by the family. Yeah, and then we call it police, they have to be admitted. When they are admitted, we admit them to a general psychiatric ward. They are usually in the acute ward for a few days, and less acute ward for maybe 2 months. But there's always a fight between us and the wards, because the wards, they have only so many beds, and just like here, I'm sure, they always have too many patients. So they are always like, I say, please, this guy is very, very dangerous. I have to admit them. And then the doctor up in the ward says, well, he might be like punching people, but he's always punching people. So what are we gonna do? And I'm like, I don't care. He's not gonna be on my watch in the street punching people. I don't know, even though we can't really do something, it's not my responsibility. I just leave him. And from their perspective, they can get a little annoyed because 20% of their beds are our patients who's taking drugs again or something like that. And they can really, they want to treat people, they want to help people, and a lot of our patients, sometimes 50% of the time they're in there because you have to somehow correct their behavior or something like that. There's not much to do in psychiatry-wise. So therefore, in the inpatient wards, they get sometimes a little tired also. But we try to do the best. In the wards, also use assessment, because I don't have time to go into, when I have 150 patients, I don't have time to go into see specific case. So sometimes we admit them in order for the doctors, in the wards doctors, to like take a closer look at them, which we don't have time to. Often it's a question of getting them off drugs. I don't know. In our wards, it's a very big problem with drugs. Is it like here? Yeah. Yeah. It's not only do the patients get mentally unwell from it, but it also creates kind of like them against us situation, because they have to be secret about it and hide it and all this. So it's something that's very, but most of the wards we cannot prevent drugs. In such a ward, doors to the wards are locked, but we are not allowed to close the doors, lock the doors to the patient rooms. They may leave the hospital if we say this is sick. Let's go to the next one. So what is it, how can you do input of voluntary medication? If the patient is agitated, we have laws regulating this. If a patient is agitated, you're allowed to give them tranquilizer or olanzapine, something like that, simply by the fact that they are agitated. They don't have to be dangerous to them. If you want them to go on long-term treatment, antipsychotic, they have to be psychotic and dangerous or in need of treatment. Then you have to go to 3 days in a row and say, I suggest you take this medication. And of course they have no idea, because they are like, whatever, hearing God speak to them or something like that. But it's something in the law that we have to say, you are going to get 2 milligrams on this and 3 milligrams on that. But it's also a way to like slow us down so we don't just push forward and treat people against that. After 3 days, they can decide to make a complaint. Then it gets to a committee with a doctor, a lawyer, and someone from the patient's organization. I should say that we almost always, I don't think it's corrupt, but they almost always agree with us. Just go back. And another thing is, with the 3-day motivation, if the doctor decides the patient is very, very unwell, very much in pain, very much, so he can start from day one, but it might still go before this committee. Yes? Then in terms of security, we use something called Worst Violence Score. Have you heard about that? No. Try to go to the next one. Oh, this doesn't work. What? How do we do it? Okay, one back. We get to the black part. Yeah, this guy. It's a scoring that you have in the wards that the nurses do in every shift. You can score 0 to 6, whether you're irritable, kicks things, shout, stuff like that. You get a number. This, of course, is something that is very imprecise, but it still helps when you have a lot of people when there are different shifts. Somebody works at night, somebody in the morning. So also like when the people work at night, they can see there was a reason so and so was done during the day because the patient was very agitated and what might be violent. Another good thing about this scoring is when you come and you don't know a patient, you can see what was the scoring over the last week, what was the scoring over the last month, because or even year, because you can see, is this patient getting slowly better, or is the patient getting slowly worse? Some of the things when you're called to a patient that you don't know and somebody tells you, oh, she's totally out of it, you have to do something now, right? And then you see, well, actually, over the last couple of days, it's gotten better. So it gives a kind of a long-term evaluation of the patient. So go to the next one. Yeah, so like I said, this is the violence score. We can give an acute tranquilizer if people are very agitated. And then we can say if people are of danger to others. And if they meet the criteria for non-voluntary admission, that means that they are psychotic and dangerous, we can hold them down. Again, then we have to write some papers. We hold them down, we held them down for like 10 minutes and so. Either that or put them in a belt restraint. And it's always a discussion. Try and go back to the next one. You see, when you're put in something like that, I don't know what we should call it, I don't know the correct word is restraint or fixation. That's very humiliating to a person. That's something that you really wouldn't like to be in that situation. So let's say a patient is agitated for like half an hour. What is worst? Is it worse that someone is holding you, or that you're in the belt? I think that depends on the person. Somebody would find it more humiliating to lie there. Someone would find it more humiliating to be held by others. In some countries, they have instead a seclusion room. Do you have a seclusion room here? Yeah. That's another way. I worked in New Zealand. They also have a seclusion room. You avoid this humiliating things about being like, actually, usually it's not with the feet and the hand, usually it's only the belt. But if the patients start hitting themselves, try to kick people, and also like very often they try to get out of the belt, so you have to put one on one leg. But still, it's not a nice situation. You should say that there's always a nurse or a guard next to them, or we try to do it in less than 2 hours that they're fixated there. I always, when we talk to the patients, they say that it's something that can traumatize patients for life, some of these things that happen. But what can you do in your situation? I don't know whether it's seclusion. The seclusion, I think, is better in that you're not like this, or you're not fixated, but you're also alone. Whereas I think, at least yet they can talk to the nurse. Now, anyway, again, after this is done, now let me start another way. Government 7 years ago said, we have too many of these fixations. We use too much force, we use too much involuntary treatment in our treatment of the patients in psychiatry. You guys, put it up again. You guys need to put the number of people being put in belt fixations, you have to put that down by 50%. And we were like, how are we going to do that? They are very, very sick. We try our best, but nevertheless, we try our best. What it has really done is we have tried to look upon psychiatry and see what could we have done sometimes to prevent these, whatever restraining in this way? And we found out over the years that maybe 50% of the restrainings we have, people being put in the belt, something that could be avoided by us. If we had just been a little bit more, try to change the subject, or tell the guy like, okay, you can, even though he's not allowed to go to somewhere, say, okay, go have a cigarette. Or back in the days, it was also like, if the patient was like shouting at the nurse, or saying something bad, foul words, and closed his door and went into himself, the staff would, and the doctor, would go in there and say, you are not supposed to, you cannot talk like that to us, and it would end up in a big fight. And now we just realize, well, the patient closed the door. That's good. We are not going to, we have to really think about some of the times that we cause the fights. Yeah. Also, like every time we put a patient in the belt like this, there will be like a crash committee, or I don't know, there will be a review about what could we have done differently. And again, the patients can complain about to a committee. Try to put